Hello, I am Govind Rajan and I am an intensivist and a cardiac anesthesiologist. Today we are going to talk about the COVID-19 induced type B ARDS. Overwhelming number of people are dying from coronavirus. The reported death rate among patients with severe respiratory failure who are intubated and ventilated is surprisingly high, anywhere between 60 to 80%. Just overnight, over 9,500 deaths have been reported in the United States, and the death toll is approaching over 70,000 worldwide and counting. In fact, there are reports of nearly 100% mortality among this subgroup in certain hospitals around the globe. It is shocking and above all raises a very interesting question. Are we treating these patients right? What we know, the majority of these patients are older with multiple comorbidities and are often immunocompromised. Most patients usually present in primary respiratory failure and in the course of their ICU stay develop severe cytokine storm and multi-organ dysfunction. I think it is time for us to take a closer look and reflect on this population demographics and disease characteristics to determine what is it that we are doing wrong and focus on what can be done differently. These patients are treated per published guidelines, and most patients are sedated, intubated, and placed on mechanical ventilation relatively early to give adequate time to protect the healthcare providers and avoid the high-risk emergent airway management scenarios. The idea is to accomplish early, controlled, electively planned intubation. It is recommended that the airway is secured if patient can't maintain oxygen saturations about 92% while on over 6 liters of nasal cannula, which means we are instituting mechanical ventilation in these patients if we saturate on a little over 40% of oxygen. Actually, the true FiO2 might be lower than 40% in some of the patients, especially if they are tachypnic. Furthermore, the other conventional non-invasive approaches such as to continue escalating oxygen therapy via high-flow nasal cannula or face mask, placing the patient on high-flow nasal cannula, or non-invasive ventilation are not even offered as treatment options. Patients are usually awake, hypoxic, tachypnic, and tachycardic. After intubation, these patients are placed on these generous initial ventilator settings per the SCCM guidelines. A PEEP of 8 to 12, a respiratory rate of 16 to 20 breaths per minute, and if the plateau pressure are greater than 30, then it is recommended to attempt recruitment breath trials and add additional PEEP with the goal to reduce the P-plat to less than 20. A number of studies from ARDSNet have reported historic crude death rate at 90 days in the range of 28 to 35%, which is way lower than the 80% that we are seeing right now. Most of the treatment recommendations of patients with COVID-19 induced ARDS is based off of the findings of the ARDSNet. For most of us, there is a singular diagnosis of ARDS, and that is non-cardiogenic diffuse pulmonary edema with respiratory distress. However, we clinically know that not all ARDS is identical. I often categorize patients with severe respiratory failure, that is ARDS, into two major categories based on type of primary pulmonary insult and its response to respiratory management. First, we have type A, where the lung injury is secondary to systemic insult. The possible causes include systemic sepsis like states like line sepsis, a dead gut, severe burns, septicemia, or septic shock, or transfusion-related acute lung injury. Now, the hallmark of type A ARDS is non-cardiogenic pulmonary edema due to capillary leak and is typically associated with lungs being wet and stiff, with significant tendency to atelectasis and often associated with pleural effusions. This type A ARDS is generally responsive to application of PEEP to improve oxygenation and diuresis, besides employing proposed lung protective ventilatory approach. On the other hand, the lesser known and frequently undefined type is the type B ARDS. In type B ARDS, the primary injury is secondary to direct alveolar insult. The possible causes are viral pneumonitis, chemical pneumonitis due to the exposure to certain dyes and industrial solvents, or thermal or smoke inhalational injury. It presents with extreme hypoxia and respiratory distress with a relatively clear radiograph, minimal interstitial edema, inflammatory alveolar exudates, and minimal atelectasis. The lungs are extremely compliant and extremely friable and susceptible to injury. These lungs are incredibly sensitive to ventilator-associated alveolar injury and consequent development of cytokine storm. As is clearly evident, ventilatory and treatment approaches that needs to be employed differs substantially between these two groups of ARDS patients. There is no doubt that these patients have progressive hypoxic respiratory failure. This extremely low intubating threshold, together with early institution of positive pressure ventilation and PEEP, is possibly inflicting significant stretch and pressure to an already injured and inflamed lung. Now, the consequences of worsening ARDS following intubation and institution of mechanical ventilation are clearly evident in observations reported by many clinicians from the field during this pandemic. It is possible that the combination of severe progressive viral pneumonitis and the ventilator-induced lung injury is triggering the cytokine storm that is in turn leading to rapid deterioration of patients' pulmonary, renal, hepatic, and hemodynamic functions. The clinicians are left with no choice but to increase PEEP, increase respiratory rate, and sacrifice the tidal volume in favor of keeping the plateau pressure reasonable. As we can see, intubation and mechanical ventilation are not the best choices when it comes to respiratory care of patients with type B ARDS. So the question is, what should we do? We have to figure out a way to administer high FiO2 with nasal cannula, with face masks, with non-rebreather apparatus, with high flow nasal cannula, CPAP, and BiPAP, and all through these interventions, we have to keep the patient awake so that they can remain actively engaged in their treatment. We should also encourage them to cough to clear secretions. Most importantly, all these options have to be developed in ways that the healthcare providers are protected. If all non-invasive efforts seem to fail, then I believe one of the following must be considered before considering sedation, intubation, and ventilation: hyperbaric oxygenation, ECMO, negative pressure ventilation. Now I know none is available today, but it is not too late to start designing and building one. Remember, we are only 10 to 20% into this pandemic, and a lot more lives are still at stake. Of course, we have to figure out a way of administering non-invasive oxygenation and ventilation without aerosolization. However, that is not a difficult problem to solve. Masks and devices that actively scavenge and prevent aerosol exposure are already available, and newer ones can be developed to meet the rising demand. That during early phase of type B ARDS, intubation, positive pressure ventilation, and PEEP can be all deadly choices. If a patient has to be intubated and none of the above-mentioned options are deployable, then the best course is not to sedate the patient. Leave the patient on spontaneous mode of ventilation, utilize moderate pressure support ventilation, except permissive hypoxia and hypercarbia. Type B ARDS is best treated with interventions aimed at keeping the sedation, intubation, and mechanical ventilation at bay. Instead, we should heavily rely on oxygenation, modalities of non-invasive ventilation, use of hyperbaric oxygen therapy, and ideally, we should aggressively start pursuing the development of negative pressure ventilators. Besides ramping production of conventional positive pressure ventilators, it is paramount that we start investing aggressively in technologies that can safely deliver high flow and non-invasive ventilation without placing healthcare workers at risk of contracting COVID-19. Further, I believe it is time to explore the effectiveness of using negative pressure ventilators and its advantages over that of conventional positive pressure ventilators in the treatment of type B ARDS patients.